Okay. Okay, I know someone was trying to join this, so we'll give it a little bit longer. Um, Give me 1 second, I'm going to put something in the chat. Okay, all right, we're gonna get started now. Okay, let me get my notes up. Right, so in this slide, we're going to talk about hypermobility. So it's something that it's come up in conversation in previous slides, but we're going to really go in depth in it today. All of what that I'm saying today is actually touched upon in a book written by Peter H. Baton, who came up with one of the scoring systems for hypermobility. I do recommend that if anyone has that to look that book up. So it's Hypermobility by Peter H. Baton et al. There's a couple of others. If you search that online, there's a whole book on that. So if you're interested, have a look. So for what we're going to talk about is background about it, sort of how we've first in research thought about diagnosing, well, it's not a diagnosis, but dealing with people with hypermobility and categorizing people into hypermobile and not hypermobile. We're going to talk about sort of how the development of research has happened over the last 50 years, what it comes from, so how is someone hypermobile, why is someone not, and then sort of what kind of manifestations in terms of pathology, in terms of conditions and issues that people deal with, how can that manifest into being problematic. So once we talk about all those points, that'll be it. So let's go over what hypermobility is. So it just refers to the ability for joints to move beyond the considered normal end range. If you look at a ball and socket joint like the shoulder or the hip, that's going to be a lot more than what would be in the elbow and the knee, for example, a hinge joint. So keep that in mind. It was first looked at in research. Hypermobility was first looked at in the 19th century, really. I mean, it dates back all the way to BC, but people recognizing that they couldn't shoot their bows straight because they had hyperextended elbows, for example. So it's something that humans have dealt with for millennia. So, but when we first recognized it was in the 19th century, where there was a major focus on trying to define some syndromes, two of which are Ehlers-Danlos syndrome and Marfan syndrome, both of which we will discuss in a little bit. But they both had hypermobility as a major characteristics in helping to understand more about the condition. Over the last 50 years, more research has been done to recognize that hypermobility can be explained as a cause of orthopedic, referring to bone and muscle deformity, and rheumatological, referring to inflammation and joint pain type of symptoms. So it's important to know that hypermobility refers to bones, muscles, joints. So we're now going to talk about where it comes from. So where it comes from is there's a familial predisposition that was first found to be the case. Give me 1 second. Okay, hold on. So there's first found to be a familial predisposition by two researchers, Finkelstein and Key. They were the first to discover that. So we know that someone with hypermobility is almost entirely down to if your parents have it, your parents' parents have it, and it runs in the family. But there's no other causes that are not non-acute that we know of. So that's the only thing that we do know. It's passed down generation to generation. After that, so following this, you have a few studies that looking at the causes of single joint dislocations, and notably they looked at the knee, cap, and the hip, and they recognized that hypermobility was more common than initially thought in causing these dislocations that happen. So we do know that although it might be passed down from generation to generation, those that are more hypermobile, we know they're more likely to get dislocations as well. As a concept, instead of thinking it as an all or nothing thing, researchers began to realize, okay, instead of it being someone hypermobile or not hypermobile, there's a scale to it. So it's graded based on the traits. So it's not as simplistic as you have it and you don't. That's important to recognize going forward. So we know that it's genetic, hereditary, and can lead to dislocation. So if hypermobility is a scale, then we need to think, okay, how can hypermobility manifest itself pathologically? So how can it then become a problem? If someone's just their joints can move really well, why is that an issue? Now, there's three different types of ways that it can then become a problem. One, it's rheumatological manifestations. I talked about that before, that means related to joint pain and inflammation. There are some manifestations that are outside of just joints, so extra articular we call it. And then there are some syndromic manifestations, so then they can then become a syndrome in someone's life. Now, let's first talk about the rheumatological manifestations. We know that it can occur at any age, but more likely, based on research, to be the younger years. So the studies looked at ages between 3 and 55 in a population, and they found that around 3/4 that were under 15 had the joint issues related to hypermobility. So, with being 3/4 the case under 15, it's more likely to be a younger type of issue. Doesn't mean you're not going to get it at 55. It's also more common in female than men. And one of the most common symptoms, it's mainly in the lower limb with effusion, so swelling, and muscle cramping that occurs alongside these issues. Also, tendonitis is found, so inflammation of tendons is also noted to be occurring often within that population in that same study. It's what we know that as well, that pain usually occurs not when someone is doing exercise, but it's usually afterwards when they're doing exercises that they are unaccustomed to. Now, we've spoke before about trying to be progressive with exercise, and and exercise to what you're capable of doing. But when it comes to minimizing these issues, you don't want to be adhering to any exercise that it's out of your depth. And that's where you're going to then pick up the pain that comes as a result of being hypermobile. So keep that in mind. Researchers have found that it's very prevalent in MSK referrals. So 1 in 5 MSK referrals will have hypermobility in there and rheumatological issues with that. So it's quite underdiagnosed, these rheumatology issues. So following this, we've got some extra-articular manifestations, meaning outside of joints. So if someone is hypermobile, they could be at higher risk to varicose veins, which some of you may have heard before, which is basically discoloration of blood vessels in the circulatory system. You could get hernias, rupture of lung tissues leading to pneumothorax. That's just a few of them. You have hyperelasticity of your skin is another symptom that happens outside of joints. So if you have any of these issues, then it's likely that you're hypermobile as well. So that somehow it can manifest outside of the joint. Now we'll talk about things that are syndromic. When I talk about syndromic, it means sort of reoccurring and happening throughout someone's life more than just once or twice. So it's important to note that there is no demonstrable hereditary disorder of connective tissue that can be recognized in the majority of individuals with hypermobility. So just because you are hypermobile does not mean that you have a hereditary issue, and vice versa. So we need to be very specific with that. There are a proportion that have specific genetic conditions. As I mentioned before, as I said I was going to get to this, is Ehlers-Danlos, familial articular hypermobility syndrome, and Larsen syndrome. Anything more minor than this becomes extremely difficult to diagnose, and you can't say for certain that someone has any of these genetic disorders. You can just speculate. So it's very difficult to be specific on this. If we take Marfan syndrome, for example, that's very clearly recognizable. They have very long limbs, dilation of the aorta, which is the blood, one of the major arteries that comes out of the major artery that comes out of the heart. So that's easily recognizable in scanning, right? But other such minor manifestations below this, they don't have a definitive feature that we can say they have this, so therefore they have mobile, or therefore they have a syndrome. So it's important to realize we can't specify things as much as we would like. We do know, however, that hypermobility can occur as a secondary manifestation of inflammatory disorders such as rheumatoid arthritis. So if you have rheumatoid arthritis, hypermobility can occur as a secondary effect. So it's important to check that. If we're going to be specific from here, and what we'll likely do is go into a second level. We'll talk about what we can do to help hypermobility. But when you're coming to clinic, it's important that we get a very good history of our clients, because we want to know, there's a determination of contributors for hypermobility that can influence range of motion of the joint is very, very difficult to determine. So someone could come in and take a variation of penicillin that may make their joints more lax on that day than someone else, or they could have a extensive family history of Ehlers-Danlos. So it's important in that clinic room to make sure that we ask the questions, so we get a full family and past medical history breakdown, so that we can better diagnose. If we don't get that, then we are unable to formulate a good enough physio plan following that. So that is something you need to realize, that whoever you're seeing, whatever therapist you're seeing, or maybe it's going to the GP, get them to ask you questions. If you feel they haven't asked all the questions you need necessary to answer whether you have hypermobility or not, then do so. And it could be something that's a little bit more sinister than just a lax joint, single joint. That's important. Now, in terms of minimizing as I said, the manifestations of hypermobility, what we know is strengthening neighboring joints is important. There are other forms of ways that we can help as clinicians, such as mobilizations to minimize pain. That's just one example. But it's important to recognize that there is no one cure, there is no one exercise that's going to cure someone of hypermobility issues. It's important that you take them through a comprehensive and progressive program that looks at all the particular joints that could be affected and deal with that accordingly. So that's how you're going to get to deal with hypermobility. Hopefully you understand a little bit more about it. We know that it's syndromic, we know that it's hereditary, and unless you get those questions asked from your GP or physiotherapist, you're not going to have the answers. So that's important to look at. Okay, so that will be it for the live today, and hopefully you have enjoyed it.